All right, so I'm going to reintroduce Dr. Justin Morgenstern. He's going to have a little bit of a different talk today. He should be showing up behind me momentarily. And he's going to talk about rapid research, so recent stuff that you should know about. Oh, there he is. Justin, all yours.
Hello again. So we're going to do a EBM lightning round here. I'm going to try to cover 18 papers that you need to know about in less than 15 minutes. So this is going to be really, really quick. My bottom line take from each paper only. If you like that deep dive EBM nerdiness, there's more details on all of these papers on the website, first10em.com. So let's jump in with cardiac arrest. We got the COCA study this year, calcium in out-of-hospital cardiac arrest. You would think it would be hard to make outcomes worse for cardiac arrest victims, but that's exactly what calcium seems to do. This trial had to be stopped early because it looked like routine calcium resulted in worse ROSC, worse survival. Bottom line, we should not be using calcium routinely in cardiac arrest, but remember to keep your eye out for those rare indications, the hyperkalemia, the calcium channel blocker overdose. They are rare, but they were excluded from this study, and they definitely should get calcium. So that study put the chill on calcium. What about a couple hypothermia studies? We got two big RCTs this year. The TTM2 trial compared hypothermia, 33 degrees, to controlled normothermia, so less than 37.5 degrees, and there was absolutely no difference. We also had the capital chill study this year that compared 31 and 33 degrees, and again, no difference. So bottom line, I think at this point, we can be pretty sure that hypothermia provides no benefit to our patients. However, almost all of these modern studies have controlled the temperature. They don't let patients become febrile. We're not sure at this point if that matters, but right now, normothermia is the place to be. What about another group of patients that we might want to chill out in the emergency department? Those agitated delirium patients. Is ketamine better than our standard Haldol plus a benzo? So there were two RCTs this year, very similar. They both gave a big dose IM ketamine, 5 milligrams per kilogram of ketamine, and compared that to our usual, the Haldol plus a benzo. And ketamine is faster by about 10 minutes. But in both studies, there were more adverse events, things like apnea and hypoxia with ketamine. So it's not perfect. My bottom line here is that ketamine is faster, but maybe not safer. In that severely agitated patient who's an immediate danger to themselves, to the department, ketamine is a clear choice. And in those patients, 10 minutes probably does matter. But if you use it, that patient should be put on a cardiac monitor and watched closely, and just be really careful of indication creep, because antipsychotics are probably still the best option for the majority of patients that we see. Now, what if you did run into an airway problem while using that ketamine? Should we use BOUGIE to improve our first pass success? And this year we had the big aptly named BOUGIE Trial, big multi-center RCT, and they compared using a BOUGIE on your first pass attempt to comparing using a stylet. And in this trial, there was no difference at all. So on its face, BOUGIE, stylet, it doesn't seem to matter which one you choose. However, there are some problems that you might want to think about, the biggest of which is that the first pass success rate in this trial was only 80%. It's not very good. There's this prior single center RCT where they managed to get a 97% first pass success rate by using a BOUGIE routinely. Which group do you want to emulate? 80% or 97%? So bottom line here is that in the average doctor's hands, there probably isn't a difference whether you choose BOUGIE or stylet for your first attempt. Personally, I'm not going to get there most of the time, but I would prefer to be better than average. Either way, we all need to be experts in both of these techniques, so practice both, master both. On the topic of getting better at airway management, the ED awareness trial is one that I think we all need to know about. In this study, they found that 2.7% of patients who were paralyzed and ventilated in the emergency department were awake and could remember it. 2.7%. Now, this is observational data from a single study, but even if you quibble about the exact number, if the number was half this, that would be way too much. Bottom line, we've got to do better. It's cruel to leave patients paralyzed and awake, especially if you're using rocuronium. You need to order your post-intubation sedation at the exact same time as you order a paralytic. I was shocked the number was so high in this study. And speaking of shocking results, the next paper is an RCT comparing pad placement in cardioversion for atrial fibrillation. For a long time that I've heard that AP, front to back, was going to be better, but this RCT actually showed the exact opposite. The anterior lateral group had a higher success rate. Their primary outcome was first shock success. Anterior lateral worked 54% of the time, AP only 33%. That's a big difference. There are some issues with the trial. It's unblinded. It's elective outpatient cardiology patients, not emergency patients. But bottom line, this is the best evidence we have, and it's enough to convince me that anterior lateral is the way I'm going to go for my patients. I think that's the end of my clever segues here. So I'm just going to have to jump around from topic to topic. But this next study is one of the most clever study designs that I have ever seen. When you're trying to figure out if CT contrast hurts kidneys, you can't really just randomize patients contrast, no contrast. There's some ethical issues there. But these researchers found a way where contrast is basically randomized naturally. If you look at emergency department patients who get a D-dimer and you focus right around the threshold and compare the ones just above the threshold to those just below, clinically, those patients are going to be basically identical. But at 505, you get a contrast CT. At 495, you don't. So these patients are basically randomized by their D-dimer result. This is an observational study of 150,000 patients, and comparing IV contrast to no IV contrast, there was absolutely no difference at all. Bottom line, I think every emergency doc already knows this, but this is the best data that we've had so far, and it's pretty clear. Contrast does not cause kidney problems. If you need a contrast scan, you should not be worrying about kidneys. Something else that we know we don't have to worry about too much, asymptomatic hypertension. Again, this isn't news to anybody, but there was a great data set out of Alberta last year. Half of all patients at triage had an elevated blood pressure. Half. When half of patients have something, that is normal. You don't get to call that an abnormal vital sign. It doesn't need to get a reassessment. But more importantly, they followed them for the next 2 years. And an elevated blood pressure in the emergency department was not associated with an increase in death, CHF, MI, strokes, none of that. So we already knew this, but asymptomatic hypertension is not an emergency. These patients should be sent home without any testing and no treatment. Next up, a quick PE update. I imagine that most people are using the age-adjusted D-dimer by now, and hopefully at least you've heard of the year score. What happens if you mix those two things together? And this is some of the best data that I've seen on the topic because it's actually an RCT rather than just observational data. And what they do is they compare what they consider the baseline now, which is age-adjusted D-dimer alone. They compare that to using the year score plus an age-adjusted D-dimer if you failed the year score. Now, in both groups, the miss rate was less than 1%. So both strategies worked fantastically, but the combination resulted in 10% less CT use. So my bottom line, both age-adjusted D-dimer and years are ready for prime time. We should be using them already routinely. This study tells us that the combo is even better. If you fail the years algorithm, you just jump in and use an age-adjusted D-dimer rather than that 500 cutoff. Next up is one of my biggest pet peeves in all of medicine. You see a kid, they have a viral illness, they don't need antibiotics, but then you give them a prescription for antibiotics to take in 2 days anyway. Delayed antibiotics just don't make any sense. So this is a multi-center RCT, pediatric patients who had your standard viral illnesses, otitis media, pharyngitis, bronchitis, and in whom the pediatrician thought there was a reasonable doubt about the need for antibiotics. And there were 3 groups. You either got antibiotics right away, delayed antibiotics, or no antibiotics at all. In terms of clinical outcomes, severity, duration of symptoms, all these groups did exactly the same. So no antibiotics did just as well as antibiotics, i.e., none of these patients, none of these kids needed antibiotics. But when you look at the delayed antibiotics group, it results in a big increase in the amount of antibiotics taken, all of which were unnecessary, when compared to appropriate care, which is no antibiotics. And the antibiotics cause harm. Diarrhea was higher in both of the antibiotic groups here. So bottom line, viral illnesses do not need antibiotics. Delaying them a couple of days doesn't change that fact. Don't use delayed antibiotic prescriptions. And then I might turn around and immediately contradict myself. So the next topic is diverticulitis. This year we had the DINAMO study. This is patients with CT proven uncomplicated diverticulitis. And they were randomized to be sent home either with clavulin or with nothing, no antibiotics at all. And there were absolutely no differences between the groups. No antibiotics was non-inferior to antibiotics. This one study by itself isn't perfect, but this is now the fourth RCT on the topic, and they all say the same thing. Antibiotics do not help uncomplicated diverticulitis. So bottom line, I think it's time to change practice. These patients don't need antibiotics, but I understand it is hard to change practice. And if this makes you uncomfortable, maybe you could ease into this practice using delayed antibiotics. Ugh, I hate saying it. Two papers on what used to be everybody's favorite drug in emergency medicine, TXA. Two RCTs, completely different topics. The first one is the NOPAC trial, topical TXA versus placebo in 500 patients with epistaxis. This is the best trial by far that we have so far. And there was no difference at all. Saline stopped as many nosebleeds as TXA did. So bottom line, we probably shouldn't be using TXA, at least routinely at this point. That is the best evidence. That being said, the study isn't perfect. The harms of topical TXA are going to be pretty limited. And look, no patient wants to have a packing done. So although I'm not going to use it routinely, if the choice is between going immediately to packing and trying TXA, I probably will still pull out TXA occasionally.